way that the advantage of the way that technology has advanced is that we can join from wherever we are, and also that this is being recorded and therefore will be available in our section on the AMEE website. And you will probably notice that that was a not too subtle segue to introduce, firstly, before we move into the postgraduate webinar, the AMEE conference in Lyon in the 27th to 31st of August, which is a hybrid conference with the conference working in 3 time zones. The last conference I thought was fabulous for having people from across the world, global north, global south, all joining in. And I think this is a fabulous opportunity to do that again. I will be in Lyon and hope to see some of you there. I'm in desperate need of face-to-face education again. But I think the democratization of education through being able to work across time zones is fabulous also. So this webinar is brought to you by the AMEE Postgraduate Committee. I have 4 wonderful colleagues with me today, and they will each introduce themselves when we get to their section. But we wanted to put this on to share with you things that we had learned in the last year through being part of AMEE and its postgraduate committee, and really to use this as a taster for the future conference, but also to encourage you to get involved with the committee, to enhance postgraduate education and training, and to bring your ideas to us. So if I could have the next slide, please. And I said everyone would introduce themselves, and then I didn't introduce myself, which is a schoolboy error at the start. My name is Simon Gregory. I'm a GP or family physician in England, in the United Kingdom. And along with the person who's speaking next, my good friend and colleague, Dr. Rille Pihlak, we are co-chairs of the postgraduate committee. You will see there that when we have a number of speakers, and as I said, they're going to introduce themselves, but we hope these topics will be of interest to you. A few bits of housekeeping that I'm going to cover in a future slide, but I just want to remind you that we want this to be interactive, so please feel free to use the chat, and please do ask any questions or make any comments. Please feel free to put in the chat who you are and where you come from, which part of the world you're in, which specialty you are, whether you're a learner or whether you're an educator or both. It would be great to get a feel for who's with us today, because I still find it very strange staring at a screen rather than rows of faces. So I want to briefly tell you about the postgraduate committee. The postgraduate committee was formed with the support of the AMEE executive, and they supported us to set this up to raise the profile and coverage of postgraduate medical education and training in AMEE, both across the organisation, in its products, and at the conference, to cooperate with other committees on research and on new and innovative developments, including those at the conference. And also we put forward symposia, workshops, and all manner of other elements for the conference and for factors such as this webinar. And we also hope to assist countries where postgraduate medical education is still developing. One of the things I learned at last year's conference was that doesn't mean us telling them how to do things, because I have found I learned a huge amount from a colleague from Sudan last year. So it is truly about working together to learn together. Next slide, please. So this slide is to summarize our activities. We are collaborating in research in relation to assessment, but also generally in research. We want to enhance scholarship within postgraduate education and training. We want to integrate with other members in collaborative work to propose strategies to assist countries where PGMD is developing, but also to share learning across, as I've said previously. We want to engage and advise trainees who would like to get involved, and to establish the committee as a diverse and inclusive committee that drives forward scholarship and sharing of good practice. We did our very best to recruit members from across the globe. Next slide, please. We sought to manifest diversity for diversity of thought in all that we do, and we ran an open process to encourage people from across continents, across nations, and across specialties. There are still a few parts of the globe that I would love to reach out to, and if you notice that your continent is missing on there, do please feel free to get in touch. We would like to be as inclusive as possible. And what you can see on this slide, which is also on the AMEE website, is that each of my valued colleagues has taken on an area in order to ensure that we have a breadth of leadership from across the committee, rather than just a few people doing things. So if you're interested in any of these areas, then do please feel to get in touch with those members of the committee. And also, when their terms of office come to the end, you might be wanting to be the next one to stand for their role. So next slide, please. So as I've said, in the chat, please would you post which country you work or study in. We'd also be quite interested to know whether you've attended any AMEE conferences before or joined in any AMEE webinars before. And on both cases, how many? And we really would like your help. We'd like your ideas of what you would like to know, what we can help you with. And Leila, who's speaking later, is our webinar committee member. And I'm sure she would love you forever if you came up with topics that we could cover in that to help support all of our friends and colleagues from across the globe as we seek to raise the profile and the standards. So I'm now going to hand over to my friend and colleague, as I said, co-chair, Dr. Rille Pihlak, for the next part of the session. Thank you.
Thank you, Simon. I hope you can all see this. So my name is Rille. I am a medical oncologist. I am originally from Estonia, currently working in the UK. And as Simon said, I am one of the co-chairs of the postgraduate committee in AMEE. What I wanted to share as kind of a bit of a recap from last year's conference was a pre-conference workshop that I did with a couple of our friends who are very interested in how we bridge from a young educator and kind of how we balance as a junior doctor our educational side. So this is just to kind of a recap of what we did and what we thought were the main parts of this whole workshop. So the workshop itself was about balancing teaching and training and tips and tricks of developing as a junior educator. And just to kind of show you, this isn't the work that I did on my own. These are my some of my very good friends who are also very interested in how we actually develop as junior educators from being a junior doctor. So the main topic of this thing was to understand and how we actually learn in the clinical environment, and how do we learn as educators, and how we as educators make sure our junior doctors learn and that become that deliberate expert from a novice, and how we push them forward regardless of what level they are. So again, this is about deliberate practice, and I think one of the highlights for myself, especially from the discussions we had with the group, was that we have to really be constantly thinking about creating that productive learning environment in a clinical setting. Because obviously I've come recently as a junior kind of doctor, as a learner, becoming an educator, and then having to work in the unit whilst we have learners there. So it's this constant mismatch of where we are and what the different perspectives are, even for that day or even for that clinic, and how we actually make sure that there is a learning environment that is willing to take that uncomfortableness of having students in that, but also make sure that we learn from everything we're doing and everything we're discussing with our patients. So I'll just tell you the whole take-home messages, because we actually have that all ready for you. I think its main thing is to actually make sure we deliberately set a climate for learning. That's mainly as a person working in that unit, a doctor working in that unit, an educator working in that unit, how we make sure that everyone's willing and interested in learning and teaching others. And actually, there's a lot of scope for learning and teaching in the clinical environment, our clinics, which we, as maybe when we're a bit later in our career, don't constantly think about, but actually there's a lot to learn, and we just have to signpost that to our junior doctors. And again, exploring the learner's perspective will help you understand and offer the best feedback. So what are their thoughts, how that matches up with my clinic day and how I think their learning went today. And getting your own feedback means actively seeking it kind of through evaluation. So again, you have to be constantly, especially as a young educator, thinking about how do I get that feedback and how will that actually make me a better educator. So the main thing is, as I said, to make sure that if we're doing on the run teaching, and this is what this session was especially about, we have to kind of prime our learners and recognize and help them recognize the learning opportunity of everything we do. This is becoming, it's kind of the socialist theory of becoming an educator, and how we actually make sure that we tell you all of the parts of that clinic day. And then as an educator yourself, making sure that every brick helps to build the wall, helps to build the course itself, which is then builds the program, and thinking constantly how my day in clinic seeing these patients could actually help that junior doctor learn their oncology knowledge, for example, and how that actually builds into a core program for them, and what do they need to know and what's not really important for them to know. So, and I think one of the things that every year we do similar sessions, I think we always have to say is that, especially as young educators, needing to balance that clinical work, being a junior doctor themselves, and then being an educator, is that you have to also be taking credit for it and try to kind of enjoy it, enjoying being an educator, constantly ask for feedback and find your community, which is exactly what we're here for in AMEE. We want to find and help the young educators, and constantly thinking about also the credit. How can this one teaching session be helpful for you in the future? How can you write this on your CV? How can you show that you've done a lot on education? So again, this was a quick recap of what we discussed in that workshop, and that was really to push forward the message that good learners make good teachers, but also that we educate our next generation of young educators, and we make sure that they don't get lost, that they don't lose their passion for education, and we build the kind of next generation of educators. So that was my quick recap of that. I'm very happy to kind of discuss in the end with everyone about everything. And then I'll hand over to Wunna next.
Hello, and thanks Leila for introducing me, and thanks everyone, and allow me to invitation me to speak in this today's event. So as Simon said, I'm Wunna and from Myanmar, and I'm one of the postgraduate committee member, and also a the emergency medicine practitioner, and also a secretary of the World Medical Association of the GATM. And today also my BATHWATER days, and would like to honor of our medical educator and health professional for their compassion, dedication, and contribution to our society and community during our pandemic. Today, I would like to talk about the effect of pandemic on the postgraduate training. Next slide, please. Of course, we saw several opportunities during a pandemic, during our AMEE 2021 and conference, and trainees said that they have improved their coping to stressful situation, and also then was also improve with other health professionals and other medical educators, and also the trainee also develop and their medical emergency skill, especially for the COVID related, and with irrespective of their chosen specialty. They developed the co-pandemic skills like the medical procedure, how to set up a ventilator and intubation and airway management and other necessary skills for the pandemic. They learn how to do the telecommunication with their colleagues, as well as the patient consultation and also with others. Next slide, please. However, they also have encounter challenges for our trainee. As saying that they have is one of the great slides, and also show about the very multi-doctors translation in the during pandemic. The workload is the skyrocketing that they have never imagined before, and staffing issue is also triple or double burden on trainee, and they also see the patient that they have not encountered in their curriculum and residency training program, and also experience immense research working condition out of their scope of practice. And also their training program also has been disrupted due to taking care of the patient, and burnout was resulted from the above mentioned challenges. Next slide, please. The key pandemic impact on our training is their physical and mental well-being. According to WHO, published in 2021 in May last year, there are 18,000 hectare water has died, and according to the water meter a few moments ago, 6.16 million people has been dying during pandemic up till now, and also their numbers are still rising, and we have witnessed trainee also witnessed the death of their patient, their family members, and their friends and colleagues and other medical educators. So coping with this amount of patient that is not included in any residency training program in any part of the world, and which is the several times multiplied that before the pandemic period. Next slide, please. So another thing unique to our Myanmar is where the military coup happened in February 2021. Since then, Myanmar trainees are doing secret health services, risking arrest and being tortured and killed and sent to prison to treat the COVID patient in secret, as military trying to arrest doctors after luring them with the COVID emergency, and also bombing the clinic and place doctor taking care of arrest. And also now the trainee doctors are now no longer in the place they lived before due to continuous arrest, and now living in places where bombs echo from the nearby fighters, and firing volley of missiles from air to COVID-19 patients and other innocent people in Myanmar. And next slide, please. Pandemic also stressed one umbrella of the trade-off during the pandemic for the trainee. The trainee prioritize the service provision to the educational that they entrusted with, and they also give up their well-being over to their own patient well-being. They had to deal with the multiple ethical decision making, like who to give a bed or who to put a ventilator, and several triage issue in the critical care in morally heterogeneous clinical environment. Next slide, please. Last year, the AMEE 2021 conference, several presenters showcased their innovative change in management strategy for trainee. but like the root cause analysis of these challenges and involving multiple stakeholders to tackle this problem. But they still need how to tackle and prepare during the disrupted time for the trainee. Thanks. And next slide, please. So my take-home message is the pandemic is the timing of postgraduate training for our trainee. So as there are several positive and negative impact of pandemic on postgraduate training, and there are also a way to improve to tackle this impact and still ways to develop consensus guidelines for training in disrupted situations like COVID and other situations. There are also several questions need to take care of, like how our work plan of trainee balance between service provision and training enforced in disrupted time. How is the trainee safety in disrupted time defined by the responsible regulatory body, and in what way are the professional and personal support and counseling service equitable and consistent with trainees' needs? And according to our leader, Aung San Suu Kyi, is that people to understand that they have the power to change things themselves. I would like to echo that medical education have showcased their power to change our medical education system themselves locally, regionally, and internationally before and during the AMEE conferences. And also would like to make sure to showcase again in next year, and also if they have the freedom from fear to changes for positive impact in the postgraduate training program for trainees. I hope several new and innovative collaborative projects and paper and scholarship and sharing good practice across our continent, and to address this impact on training during pandemic in upcoming AMEE conference in Lyon 2022. Thank you all, and over to our next speaker, that is Gustavo.
Yes. Welcome, ladies and gentlemen. I am Gustavo from Brazil. I am a gynecologist and I work with PG training and assessment. Currently, I'm a member of the AMEE postgraduate committee, where I'm responsible for community engagement. I would like to thank the organization for this great opportunity. Today, we will be sharing some thoughts on the effect of the pandemic on the balance between service and education, inspired at the last AMEE conference. Next, please. For this presentation, I have no conflicts of interest. Next, please. Today, we will start by considering some PG training diversity on service and education. After, we will discuss the effect of the pandemic on services and PG training, and finally look at the lessons learned from the pandemic. Next, please. As we know, there are different routes for unsupervised clinical practice. In North America and some countries in Western Europe, PG training is required for autonomous clinical practice. In contrast, unsupervised clinical practice is allowed in other countries with no PG training in some circumstances, such as rural areas, primary care, or emergency. Next, please. There are some differences also in terms of the participation of the trainees in the health service. In some situations, the health service is only partially dependent on the trainees' workforce, which means more protected time for learning, assessment, and better educational outcomes. But sometimes the health service is fully dependent on the trainees' workforce, with an overload of service and no protected time for learning, resulting in poor educational outcomes, stress, and burnout. Next, please. During the pandemic, many changes in PG training reflect the social accountability of medical schools and PG training programs. We should remember that PG trainees represent a vital force in any country's healthcare system, and they are expected to assist in disaster situations. Next, please. As Wunna has shown, there were many consequences of pandemic on service. PG trainees were moved to COVID frontline, elective surgeries were canceled or postponed, and outpatient care was rescheduled or moved to telehealth. Next, please. Considering the effects of the pandemic on PG training, there were positive and negative consequences. Some favorable aspects were more opportunities for training in some areas, such as emergency and critical care, as it was shown. There were also improvements in e-learning and virtual simulations. The unfavorable aspects were the restraints for training in different medical specialties, lack of supervision and assessment, and work overload, stress, and burnout. Next, please. The pandemic severely changed the balance between service and education. The health service demands for COVID patients increased, while opportunities for education in many medical specialties decreased. There were also limitations for trainees' assessment, and so the full impact of the pandemic on PG training is still not known. Next, please. We can conclude that there were many effects of the pandemic on PG training, both favorable and unfavorable. But now we have an excellent opportunity to change, to reflect, and improve PG training curriculums worldwide and make them more versatile, flexible, and available to respond to unexpected health needs. Online education and virtual simulations are now options to improve PG training, but are not replacements for clinical settings. Next. Thank you very much for your attention.
Okay, thank you so much, Gustavo. This was an interesting, impressive, very impressive presentation. I was happy to see it another time once again, because of course I saw it last year in the virtual Congress. And the next presentation will be mine. I will tell you about the postgraduate reform in our land, in our country, what I have learned and applied from the last year Congress. And Simon, you asked about how many AMEE congresses we have attended. So I attended my first one in 2002 in Lisbon, and then I missed 2 congresses, the one in 2010 in Glasgow and 2013 in Prague due to other engagements. So I have attended 18 AMEE congresses, and I can tell you that the AMEE Congress is always the highlight of my work year, and I go there and be kind of bulimic or whatever it is, try to have so much information as possible, and I will live with that for the next year. And I will share you one of the greatest ideas I had from last year's Congress. So the background about Finland before the reform we have about 5.3 or 5.4 million people and 22,000 physicians. And we have 5 autonomous universities. And that's a challenge because we are drafting a national postgraduate education program. So these 5 autonomous universities, they have to agree, and that's not always a smooth sail. We have 50 medical and dental specialties. And the education is regulated by the Ministry of Health and Social Services, who gave a statute in 2020. And that was the starting point for this competency-based medical education. We started the reform in 2018, but in 2020, it became reality. And before this reform, we have had time-bound education, and both residents and supervisors are workforce. And we have a traditional master apprentice model. Here on the right-hand side, you see the outline of the previous education, and you see that in the middle of this table there are these regular evaluations, and the residents protested widely because they didn't take place. That was a nice thing in theory, but in practice it didn't work. And we started with great enthusiasm with this Elaine van Melles and co-workers model published in the Academic Medicine 2019. So we have an outcomes competency framework that is a national study guide which was published in August 2020. And that was a revolution because all the 5 universities agreed to have one study guide. Before that, they all had individual study guides. And then we started building our EPAs and milestones, that is progressive sequence of competencies. And the EPAs and milestones, they serve as a roadmap for the residents and their supervisors, the clinicians. Then we started constructing learning experiences tailored to competencies so that the residents have trainees, they have a chance to learn those skills and processes they are expected to learn. And then teaching tailored to these competencies. So it's kind of, we started, or we are supposed to supervise our residents as coaches. So not just lecturing or teaching them, but to coaching them to reach these competencies and to be trusted members of our community. And then the 5th step is programmatic assessment, which is still kind of science fiction. We don't have a tradition of assessment in our resident or trainee education system, so we have to start this in scratches. And here are the 3 parts I'm working on right now. And then I had this attended this great plenary by Professor Dylan Williams. And because I started with great enthusiasm and believed that I'm going to change the world and it will be much better than it was. And then I learned that there are no perfect solutions, only trade-offs. And the reformers like me are often silent about the things that the old approach did well, and the new proposal might not do as well. I had never thought about that. And the other question was that what will be worse if the changes are made? And the obvious answer is that nothing is going to be worse because everything is going to be brilliant and better. And after this plenary session, I started to think that, well, perhaps we should focus on the things that the old approach did well, and also answer the question, what will be worse if the changes are made? So the lessons learned is that I should start with identification of the good things we have. And the good things are that we have the reform supported by all stakeholders because we will have something for them. But I forgot to identify how do the existing structures support the implementation of competency-based medical education. And 1/3 of the specialties do quite well. They have very good structures and need only minor reforms. But then there's 1/4, 24% of the specialties that need major reform, and I will have to focus on them a bit more. And then we should not throw the baby away with the bath water. So we have to explicitly commit to patient safety. And here we have the importance of wording, because we are doing quite well already. But if I start talking about assessment and focusing on patient safety, meaning that it was unsafe before, so that's not a good idea. So it's importance of wording, so all feel safe, the patient and the trainee and the supervisors, we all feel safe. And then we have to focus on our profession as a community of practice, because in our country, this practice is not so evident now than it was in 1960s when my father started as a medical student. So we don't address each other like Dr. Niemi-Murola, but we are all kind of colleagues. We are brothers in arms, and the medical students are part of this community from the day one. So I'm expected to address our dean as Anne, because that's her first name, and not a dean or Professor Remes. We are all colleagues and brothers in arms, and they are part of this community, and I think it's great. They don't have to do anything to be accepted. They have been admitted to medical school, and they are one of us. And then we have to focus on this master apprentice, but point 2. So now we have structured outcomes, and we will have observations and feedback discussions instead of assessment and giving feedback, but we have observations and feedback discussions. And then we have supported practice and entrustment. So we'll focus on the good things. And one other thing is that I should be very explicit with the reform and tell what is good and what we are in a risk of losing if we go too far. And it won't be a smooth sail, but I believe that the future will be bright. And this is a picture from our summer house, and you can see the 2 swans swimming there very smoothly and peacefully. And that was my presentation. And then we go back to Leon and Simon. Do you wish that I will keep this slide here, or should I stop sharing?
I think it's fine to stop sharing now. Thank you,
Okay.
Leila. It would be nice to be able to have the faces on screen. So firstly, I wanted to say thank you to our attendees for attending, and I hope you'll stay with us for a few moments longer for the questions. But thank you to each of you for your presentations. Interestingly, some of the things you brought up from the conference, I remember hearing at the conference, but not quite in the way you put them today, and it helped my learning to hear them again and through the ears of somebody else. And I think that's a learning point I'll have from today's webinar. I did also want to say I love the idea of everybody from day one being part of the community of practice. I suspect that not every country lacks the hierarchy as yours does. In fact, I know my own doesn't, although I think I remember best those teachers who treated me as a colleague from the start. But also, I wanted to reflect something that I heard at the conference in one of the plenaries. One of the speakers said that at the point of that conference, there'd been 113 armed conflicts since the year 2000. And as we were talking about the impact of COVID on learning, we shouldn't forget the impact of armed conflict. And I'm struck by the bravery that's been referred to today of our colleagues in Myanmar. And I thank you, Wunna, for reminding us of that, and indeed for your own courage in speaking up about that when I realize that comes with some risk, but also very conscious of the war in Ukraine at the moment and how close that is to the countries of 2 of my friends on this call as well, and the impact that has on everybody, whether it's about the care they're needing to provide, the fear, or the impact on their training. There are so many aspects. I think it's really important that we reflect on all that disrupts in our lives and in the bravery of our profession. So thank you, Wunna, for bringing that to us today. And thank you to colleagues that have introduced themselves, and also to AMEE that has relieved the tachycardia of the chair in asking a question. I think it's a great question. Do you think that medical educators are well prepared for the next pandemic? And I would say before the pandemic, I was talking to a professor of infectious diseases who said that there were 10 viruses competing at the time, but his money was on coronavirus. So it really powerful question. I wonder, feel free just to take your mics off and tell us whether you think we're ready for the next one. Not that this one has stopped yet, of course. Oh, it looks like AMEE might be able to join. All the other colleagues are appearing on screen, which is fabulous. So AMEE, you might want to ask the question yourself rather than have me read it for you.
I mean, I think we can start answering the question as well. I think, I mean, it is an interesting question. I think we, throughout pandemic, got the same question about the time as well. You know, are we coping? Are we helping? Are we doing better? I think we definitely got some very, and as we literally saw here from Gustavo and Wunna, especially of what's happened during the pandemic, I think we got really good areas that got better, got really innovative ideas, and we're actually able to implement them very quickly. So I think there was definitely some good sides that we saw and will hopefully help us deal with the next pandemic, although I don't even want to say those words. But I think I think we're definitely, you know, now more prepared because we can actually believe that it can happen. I think a lot of us did not believe that the world can stop for 2.5 years. But I think we can definitely do better. I think there's a lot of issues we haven't dealt with still, especially when we're talking about trainee well-being, doctors' well-being, you know, healthcare professional well-being. I think we're not over that curve yet. So depending on how quickly the next one will hit us, I don't think we are prepared for that, just because our people are quite burned out and we haven't dealt with that in a way that it actually is truly impactful. So I think that from an educational perspective, there's a lot we can do. And I think from an educational perspective, there's lots of good ideas whether we need to continue. And there is still a bit of a tendency to go back to pre-COVID times and take the tools we had then. Yeah.
Yeah, and of course, whilst we still have the pandemic, we also have the long-term effects of that, whether it be long COVID or displaced care, delayed care, or even the economic impacts or mental health impacts that mean that the workload isn't reducing as we speak. You triggered something for me in your question also, AMEE, that in my organisation, Health Education England, we just had a consultation with people about the future of medical education and reform. And one of the respondents said that medicine was so traditional that we don't change things, and it would take a global pandemic or World War III to make us change. And I really wish I'd not heard those words, because it then became true. But actually, we've had a hard reset, and I think we've all got to challenge now, as well as being ready for the whatever comes next. I think we need to stop doing some of the things that we do because they were done in 1600. And that might include some elements of curricula. It might include some elements of medical practice. It might include things like high stakes examinations. And it might be time to ask, what do we really need to do? What can we stop doing? And how can we better look after those we seek to serve? And I use that phrase purposefully because I mean all of our colleagues and our patients and citizens by that.
And I would like to comment on this. The University of Helsinki was established or founded in 2040, and we are in Finland, we are traditionalists, but on the other hand, we are also very ambitious as teachers. And usually we are about 70 medical or clinical teachers in attending each AMEE Congress. and it's kind of if you don't show up yourself in there, you are dead, you don't exist. So, and everybody is competing, that we are trying to be very innovative and creative and so on, and everyone is trying to be better than the other one. But the good thing is that when the pandemic hit us, so we had already started with the or the electronic or digital examinations, and our dean had made this decision in the autumn 10 2019 that we should have all the examinations with the computers in order to avoid the papers and so on. So we had a very good start. It was a shock for some teachers, but most of us already had experience of lecturing with Zoom or Teams or so on. So my recipe for this survival when the next pandemic hits us, that we should follow our time and have many tools in our kind of tool basket. So if you are just a traditional teacher with traditional lectures and so on, so then the pandemic will hit you hard. But if you are like a tennis player, so moving all the time from one corner to the other and practice everything, so it's not so very difficult for you to change your whole practice. So I can recommend these AMEE congresses, because you will have many good ideas in these congresses. Thank you.
Anybody else like to say anything?
No. Yeah, thanks for this question.
Wunna, please.
Thanks for this question. I think that we have learned a lot of ideas and decade during our AMEE 2021 conference. We have learned a lot of strategy to prepare for the next pandemic. Like we have. As we all know, for the well-being of the trainee, which is not clearly addressed before the pandemic, is now focus on every medical school curriculum and the postgraduate curriculum, as well as medical deans and so on and so on, has been focused on this trainee well-being. And we also adapted to learn from the graduate assessment. And also the graduate examination, and also the daily education with our trainee and also other people. So I think to answer this question, I think we according to reflection from previous experience, I think we can. I'm not quite sure to say that we're prepared, but we are better prepared than before the pandemic and for the next upcoming wave or upcoming pandemic.
Thank you. Gustavo, did you have any thoughts?
Yes, it's a good question and an important discussion. I was thinking about to try more flexibility in curriculums. I think it's very important. And I was thinking about the Leila presentations. The EPA, Interested or Professional Activities, can be a very interesting way, because you can prepare our PG trainees for unexpected new situations. It could be included as a new EPA or a milestone, but I think we should be more prepared than we were, and there's no results on trades-off. We need to try, but to get more flexibility, I think it will be very interesting, because the most part of our training is traditional and sometimes inflexible. And so flexibility for training, flexibility for assessment, flexibility for entrustment. Perhaps we could include.
Yeah, I think I just want to thinking exactly the same when we were all talking about BASE, the same thing. We're talking about the flexibility, the I think there's always this question of like, how we actually ever proven that the high stakes exams make better doctors, right? Versus that people that do this every day, that's where the EPA started from, whether we trust them to do it, right? Whether we trust them with this task of dealing with this patient or doing this exam on them. So I think, I mean, again, someone should now do that research and be, are these doctors different? Are these doctors that couldn't do the high stakes exams, for example, on patients who are actually, you know, are actual actors? Are exams that they did or things that they actually got from EPAs or similar things to EPAs actually better doctors? So I don't know. It's always to me, I feel like maybe it's my pet peeve of trying to understand whether this actually scientifically makes sense, or if we're making different training, different doctors.
So you trigger two things for me there, Rille. One is a note that Gustavo did something that I forgot to do in this, which was declare any conflicts of interest. And I think we've got to get better at doing that, because many educators are also examiners, and it may be a significant part of their work plan or of their own investment in what they think they've achieved in their life. And that will take some handling. The other thing is that we do have some naturalistic experiments at the moment. So many countries, they suspended the examinations and restart them. Some didn't restart them and use different methods. And I think those will give natural cohorts. Certainly in the United Kingdom, we didn't do it significantly for high stakes endpoint examinations, but we did do it for selection assessments, which were changed. And we did, thankfully, think at the start, we need to tag the doctors recruited through that new route into the database, not labeling them, because what we didn't want to do was create stigma, but tag in a way that later on that can be used by research to find if there is any difference. And I'll put my head on the block and say that I don't think there will be any worsening of standards from the different assessments, but there may be some sense of loss for those of us that enjoyed doing them, which I do mean the assessors, not the applicants, because I don't think I've ever enjoyed a job interview. I don't see any other questions coming in. If anyone that's on AMEE, because we've had so few join us today, which is heartbreaking, but because we've had only a few join, you have been activated. If any of you would like to ask a question, I'll give it a little moment to see if you do. And if you do, great, and we'll discuss it, and we will finish by 3, I assure you, because I'm in another meeting at 3. And if you don't, then everyone can have a bio break. Rille.
I mean, I think one of the things that I was listening to Wunna's thing that I thought maybe would be interesting to discuss is that we, as you mentioned, is that we've had to now have trainees who feel, you know, been put into a completely new environment, that's changing every day, having to treat COVID patients, for example, having no knowledge of how, you know, how exactly these patients should be treated. But at the same time, they had educators or their supervisors who were exactly in the same position. So I think this is a very unique pandemic, and also I completely get the same would be in a war or a conflict situation, that we have people in a situation where the learning has to be done by both sides, which is unusual, and I've seen, at least in our situation, because I deal with cancer patients and what can they be doing in COVID situations. Every side is completely just looking at the other, asking the same question. So I think that's actually done also a very intriguing learning environment, And I've seen, I think, some amazing examples of international learning from that, you know, people get really activated and really ask, you know, ask Twitter, basically, how should we be treating these patients? But I think it's gotten, again, maybe just another tick box in my head of another idea that could be research of how that learning helped on both sides, and not only and whether that leads to a better learning environment, because everyone is in the same position. No one knows the real good answer. Yeah, just a kind of a topic that I was thinking about.
I think a very good point on which to end, actually. There's so much more learning that we can gain from this. And I think there will be a much greater degree of democratization of medical education through much of that learning you've talked about. And I think we then perhaps might finish with Gustavo's point about flexibility. And I think that will be one of my main take-home messages from today's webinar, is the opportunity to be flexible. Can I remind people that we brought this to you from the Postgraduate Committee because we wanted to promote the committee to you, and I hope that by this recording going on the website, it will be able to be used in that way and will be circulated by AMEE. I want to thank all of you for joining, and I hope that you will continue to pursue your taste for postgraduate medicine, including possibly connecting with us either before or at AMEE in Lyon. I think it's going to be a fantastic conference. I'm planning to go to both conferences, Ottawa and AMEE, if possible. Although my family don't know that yet. But looking forward to it, looking forward to having a great time with you all. Thank you for joining. And given that we are still in the midst of the pandemic, thank you for all that you do, for your patients, for each other and yourselves. Take care and enjoy the rest of your day. Bye-bye.
Thank you. See you in Lyon. Okay, bye-bye.
Bye-bye.
Bye, everyone.